So can I share screen again?
Right now, I'm going to share just the opening screen, and then the first presenter will be able, I will then stop sharing, and the first presenter will be able to share. Okay, I think we can let everybody already come in. And I will start with welcoming the participant in a couple of minutes, and it will be the start. Hello, everyone. Welcome to today's workshop, Systematic Screening for TB at Clinical Settings. Don't miss the TB patients at hand. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Your microphone has been muted to avoid background noise. We encourage you to turn your webcam on throughout the session when you can. Can we please ask you to change your display name to your name and country? Click on Participants on the bottom menu bar, hover the mouse over your name, click on More, click on Rename, enter your name and country on the screen name field, and click the OK button. You will have the opportunity to submit text questions and comments to today's presenters by typing your questions into the chat. You can send questions via the chat at any time during the session. The moderators will collect them and address them after the speakers' presentations in the allocated Q&A sections. You will have the opportunity to intervene in today's sessions by submitting a request to do so via the chat or by raising your hand. The moderators will record your request and inform you when you can intervene. They will have the opportunity to provide feedback in the end of the session evaluation survey, which will appear directly in your browser once the meeting closes. It's important you complete the survey right after the workshop, as the link will only be available for a short period of time. You will receive a certificate based on your attendance and the completion of the evaluation survey. Finally, please note that this session is being recorded and the recording will be available to the public a few days after the session. It is now my pleasure to introduce you to today's chairs, Dr. Ikushi Onozaki and Dr. Bintari Duyardiani. Over to you.
Thank you, Caroline. I think Dr. Okada then have some announcement before starting.
Okay, thank you. So good morning, good afternoon, and good evening to everyone. I'm Dr. Okada from RIT JATA, a coordinator of this workshop. As you know, we need to accelerate TB case detection to make up for delayed diagnosis and reduced notification because of COVID-19 pandemic, as well as to fill the persistent gap between notification and incidence. The roles of chest X-ray in TB case detection has been rethought recently, especially because of its high sensitivity and moderate specificity, and the development of AI CAT. So this workshop aims to promote a more active use of chest X-ray in systemic screening through sharing experiences from the field and scientific research, followed by a group discussion. One thing I'd like to say is that we are going to discuss not only clinical settings at hospital, but also in community outreach settings, because the experiences in active use of chest X-ray for TB detection mainly comes from active case finding in the community, but not many from clinical settings where passive case finding is in mainstream for TB diagnosis. So now I would like to introduce two chairs, Dr. Ikushi Onozaki from Japan and Dr. Bintari Dwi Hardiani from Indonesia. Dr. Ikushi Onozaki moved back to research into tuberculosis out of Japan last year, completing his service as a staff member of WHO Global TB Program since 2007. He is a pioneer to implement TB prevalence survey and active case detection in TB high burden and resource limited settings. Dr. Bintari Hardiani is a public health professional who has been working in TB control in Indonesia and currently a manager of Zero TB Yogyakarta project for ACF. She has provided technical assistance to the TB prevalence surveys in Indonesia, Nepal, Myanmar, DPL Korea, the Philippines, and Mongolia. So I hand over the microphone to Chair. Thank you.
Thank you, Dr. Okada. So it's my pleasure to co-chair the session with Bintari, so my ex-colleagues in Myanmar as well as Indonesia. So let's proceed the plenary session. So we'll welcome the 6 speakers instead of 5 in the original program. So first 2 will show you potential impact of ACD and case detection of chest X-ray on country TB epidemiology. Dr. Seiya Kato, Director of RIT, will review experience in Japan that showed annual decline of TB around 10% for 2 decades, so around 2060s and 70s. And Dr. Tien Shibanda, Deputy Director of National Center for TB and Leprosy Control, Cambodia, will show changes in Cambodia. Cambodia had significant decline of TB incidence as well as notification for more than 10 years, graduating from WHO's TB high burden country list by recent WHO update. Then we'll hear from my co-chair, Dr. Bintari from Yogyakarta, Indonesia, her recent experience of ACD project with CAD. I did have privilege to work with her in Indonesia survey and WHO Myanmar. Then we will have a special additional speaker, Ms. Sandra Kick from FIND, to brief us development of portable X-ray and CAD, followed by Dr. Len Holben, who is an associate professor in London School of Hygiene and Tropical Medicine. Since our expected speaker, Beatrice, has an unavoidable appointment this afternoon, Len will kindly talk about role of X-ray for detection of subclinical TB on behalf of her. He is a co-head of TB modeling team there too. Last but not least will be Ms. Kins Eman, who is a project management professional. She is currently leading the Dopash Foundation, so she will show us promising achievement of ACD in Pakistan despite the pressure of COVID-19 pandemic. So we'll have short break then after these presentations, followed by QA session after the completion of all 6 presentations. So we'll collect questions via chat function. So then we'll check one by one, then so move to the question and answer session after all 6 presentations and the break. So let's move to presentations. Dr. Kato, the floor is yours. Thank you.
Hi, good morning, good afternoon, good evening, depending on the place where you are. So I would like to share my, can you see my slide? It's okay?
Yes, yes.
Thank you very much. So my topic today is role of chest X-ray mass screening in TB control in Japan. I have no conflict of interest to report. This panel shows a trend of TB incidence and death in Japan. In 1951, incidence of approximately 700 over 100,000 population, which is very high even among current high-burden countries. TB was #1 killer among all cause of deaths. So TB was caused national disease. In 1951, government enacted TB control, which include almost all components to reduce TB burden. The prevalence survey were conducted every 5 years between 1953 and 1973. A rapid decline of incidence was observed between 1960 and 1980. Especially between 1965 and 1978, we had achieved average of 10% decline of incidence, which is equivalent to target of end TB strategy between 2015 and 2055. After 1980, we experienced stagnation of TB incidence decline. The factor was aging pandemic, that is old generation, which got infected with TB, developed active TB due to immunosuppressive condition caused by aging. And the other factor is urbanization of society. In late 1990s, incidence increased and government declared TB emergency in 1999. The decline rate went back to average of 5%, and current incidence in 2020 was 10.1 over 100,000 population. So we conducted prevalence surveys every 5 years, and in the prevalence surveys, target areas were selected randomly by stratification of urban and rural areas. Questionnaires, tuberculosis skin test, and chest radiograph were used for all target population, and sputum examination was added to the TB suspect. The examination rate from selected population was very high, and in the first 2 surveys, prevalence was much higher than was expected. The prevalence went down from the 3rd survey. So this panel shows the infection cycle of TB. The people get infected to TB and become LTBI by the contact to the source of infection, who is usually smell positive patient. Among LTBI, 10 to 20% develop active tuberculosis, but they are initially asymptomatic. If the disease progress, patient becomes symptomatic and infectious. And we have tools for intervention in each step. BCG and LTBI treatment prevent LTBI to develop active TB. And screening detect not only asymptomatic TB, but also symptomatic TB cases who does not present him or herself to medical facility. A social determinant for diagnosis and treatment should be shown in this yellow box. The TB screening in the community can be a solution for social determinant, such as poverty, stigma, low awareness, competing priorities, financial barriers, poor geographic access, weak health system, and health insurance mechanism, and so on. And early detection of symptomatic patient is important to reduce infectivity and infection period. And in Japan, every intervention that's shown in this panel was implemented based on TB control role. So this panel showed a proportion of the tuberculosis medical expense over a total medical expenses. Tuberculosis medical expenses were 65.4 billion Japanese yen in 1955, accounting for 27% of total medical expenses. In 1975, the tuberculosis medical expense at the peak of 235 billion Japanese yen, but proportion was only 3.6%. That is, the proportion reduced by 1/10 in 20 years. So the ample investment for TB control are very cost effective. from this data. The first previous survey in 1963 revealed that 3.4% of the target group had TB. It implied that TB burden was much more serious than was estimated. It was also very important to know that only 21.4% of the detected TB cases were aware of TB. Based on this result, TB control was strengthened. As for screening, target was expanded from the people below 30 years old to all people except for baby. And the public fund subsidy for screening was enlarged in 1954 and finally became 100% on 1957. The second previous survey in 1958 revealed that 3.2% of the target group had TB. So the decline rate was only 0.2%, which was disappointing in those days. The special promotion project, which includes strengthened screening and case management, was implemented in 1959 in the quarter of the health centers as an operation research. As for screening, allocation X-ray van and encouraging referral to clinic were implemented. With these efforts, incidence started decline, and the third survey in 1963 proved decline of prevalence. In conducting mass screening, development of innovative technology was crucial. Photofluorography enabled to take chest X-ray with minimum cost. Japanese radiologists developed photofluorography completely independent from Brazilian researcher who was acknowledged as inventor of photofluorography. This innovative technology was applied to screening for newly recruited soldiers and operational research, which revealed that approximately 20% of the target were TB subjects. In reading photofluorography, a physician used magnifier as the film size was 70 by 70 millimeters. The training was provided to the physician as it requires special skill. Screening was conducted at school, workplace, community, and so on, and the government ensured funding for the screening. And tuberculosis control law stipulates the responsibility for implementing screening to the head of the organization. It includes school, workplace, welfare facility, municipalities, and so on. An X-ray van was used for screening from 1960s. So this panel shows the role of civil society in promoting screening. The first anti-tuberculosis women's association was organized in one prefecture in 1957 when outbreak case in a primary school occurred. Mothers stood up to protect their children from tuberculosis. This is the film produced in 1959 showing the house of the local women's health association advocate and encourage community members to take screening. They also work for fundraising with Christmas tree campaign to be used for the activity. And recently the fund was collected from Christmas tree campaign was used for international activities of JATA. The photofluorography was widely used for screening. In 1951, the case detection rate was 0.7%, which proved efficiency and effectiveness of screening. Based on the result of the previous survey, target was increased in the following 20 years. However, the number of the detected TB case screening was not did not increase. It is because the case detection rate go down in the following years, and maybe to declining incidence and establishment of health insurance. Fourth previous survey in 1968 showed that child cases was decreased markedly, so screening for pupil was streamlined in 1974. The report by National Tuberculosis Advisory Council in 2000 recommend to reduce the chances of screening because of the efficiency. So number of the examining decrease from 2000 after 2000. The public health insurance was established in 1961. People get medical treatment at any clinic or hospital by showing health insurance card. Cost coverage of employee was 100%, while that of the family and others was 50% on start of health insurance system. But now it is 70%, except for people aged over 70 years old. In 1960s, actual number and proportion of the TB cases detected through screening decreased markedly. Global rate is because of the establishment of health insurance in 1961. Patients were benefited from the public fund subsidy for treatment cost. However, medical cost before diagnosis was not covered by the TB National TB Control Program, and was heavy financial burden for people. So introduction of the health insurance made it easy for a symptomatic patient to consult doctor earlier. So this is a summary of my presentation. X-ray screening contributed greatly to case detection from the following ways. In 1960, health insurance before health insurance introduced, 28% of the cases were detected through screening. It is before health insurance was introduced. Medical cost before diagnosis was barrier for consultation to the doctor, and among patients detected through screening, only 21% of them are aware of tuberculosis. Collaboration among national government, local government, private sector, and civil society was important. Government ensured funding, and TB control stipulate responsibility for implementing screening to the head of the organization, such as school, workplace, welfare facility, and municipality, and so on. Local anti-tuberculosis women's association encouraged community members to take TB screening. The establishment of health insurance in 1961 accelerated early case detection by reducing financial barrier for people to consult physician. And thank you very much for your attention. That's all my presentation.
Thank you, Dr. Seiya-Kato, for presenting the strategy of Japan in controlling tuberculosis since the year of 1950s. It's very interesting lesson learned for us. So we welcome the next speaker, Dr. Tiang Silvana, the Deputy Director of SINAT, the National Center for TB and Leprosy Control of Cambodia, the downward trend in TB notification after nationwide DOTS decentralization in Cambodia. Dr. Silvana, the floor is yours.
Thank you. Good evening from Cambodia. Good morning, good afternoon, everybody. Today I'm very pleased to. Oh, where is your share? I don't see. Oh, my screen. I don't see the slideshow. Could you see the slideshow?
Yes,
my slideshow.
We received your PowerPoint, but not yet in slideshow mode.
But I could not find from my computer.
Press F5 on your keyboard. Press F5 on your keyboard.
Already, I already press F5. Yeah? Might be again. Maybe I should.
That should be fine. Let's go on.
Now that okay now? Not yet okay, yeah.
No, I can see your slide.
But on slide mode or not yet?
Not slide mode. Not slide mode.
Not yet,
Oh,
not yet.
so we I should exit and then again.
Please.
Why not show on my computer? The might be more.
Banna, you can present by this mode. No problem. We can see clearly.
No problem.
Yeah, we can see clearly. Yeah, that's fine.
Oh yeah. So sorry. Now interrupt. Again, thank you so much. Now I would like to proceed to my presentation. As the chair mentioned, Cambodia TB controller do the great job in terms of using the TB incident. That's why the Cambodia recently from the list of 30 high burden country with TB. The reason will show on the following slide. Yeah? We have no conflict of interest. This is the outline of presentation. I will talk the first part about the downward trend of TB innovation in Cambodia, followed by the historical of the strategy, including the expand strength of the dot to primary healthcare, and then the third bullet we will introduce about using our positive negative presumptive TB, and other factor we should consider that could bring the incident down, and also the downward trend of the TB notification. And the last point from our future perspective of the Cambodia NTP. This the trend, the slide show the trend in TB notification per 100,000 population. You may recall in our country, we Cambodia NDP introduced the dot strategy seen in 1994, and then between 95 till 99, dot available only at hospital level. And then from 1990 till 2000, we together with the Cheka project during the time do the pilot decentralize the dot to the primary healthcare level, and then by late 2001 till 2004-5, is the period of the dot expansion to health center. So we can observe before the dot expansion period, the case not yet detached so much, but during the dot expansion period, we can observe the sharply increase of case notified both the smear positive in the red color, the smear positive increase seen the 2002, the early dot expansion till 2005-2006, as well as the smear negative also increase. However, since 2007-2008, it seems to be the smear positive again only increase, while the smear positive and extrapulmonary still continue to increase. Just for your information, in Cambodia from 2013-2014, we use the new revised case definition by WHO, the so-called bacterial confirmed TB case and clinically diagnosed TB. The dot part of the dot expansion, we expand the TB-CV in I talked earlier, between 94 till 99, we check over 35 hospitals only. From 1999 till 2005, we destroyed but two primary healthcare in our country. We call health center, cover all the health center during that time, 853 health center. And we established the spectrum transport system from the health center to TB laboratory. And also, just for your information, in our country, one health center cover approximately 15,000 population. And during that time, we use also the CHRA for smear negative presumptive TB. After negative smear examined by smear, we use CHRA to make judgment of diagnosis whether active TB or not. And we also provide capacity building, including quality of email and interpretation since 2003. And now the history, the CHRA available at the public hospital, just 58 in around 2004, and then increased to 89 in 2010. And now we have 128 CHRA machine. This this slide just focus on the main important survey that the NDP together with the partner WHO, especially the OIT Jakarta during that time. Dr. Onusuki, remember we do a lot like the prevalence survey. We do 2 times already. The first one conducted in 2002, the second round 2011. For the HIV seroprevalence survey conducted by NDP 4 times already, 2003, 2005, 2007, and the last one in 2009. A national tradition survey, we do 3 rounds. The first one in 2001, the second one 2006, 7, and the third tradition survey conducted in last 2 years, 2017. And for the systematic survey, I will talk in a few slides. And from that, you know, from such important survey that the result get from that survey, this can provide the evidence base for decision making for policy and as well as strategy development. And also from the experience of the first national prevalence survey that we conduct the first time in 2002. From that experience, the Cambodia NDP able to conduct the active case finding ever the first time in 2005. This slide just show you about the hierarchy or the chronological order of intervention. Just the history again between the 94 till 99. This is like not available only at the hospital. We call the hospital bed and collaboration partner, especially WHO and Jakarta. And we continue to expand until 2005 to cover all the health center. The funded by Jakarta and some from WHO. And if we look on the 1999 till 2004, this year we at the same time of the dose expansion period, we include several components like we improve quality of implementation, we improve laboratory activity, and including drug management. We strengthen also during that time till now. And we improve the quality of reporting and promoting in terms of IEC advocacy. And late 2004 also, we introduced the concept like the intervention committee by TB care in our country. We call community dose and collaborative TB HIV. And we promote the use CHRA for smear presumptive TB and the childhood TB intervention. For the second phase of the project, cover period 2004 till 2009, we add on the intervention public-private mix and the DRTB activity. They are in line with the so-called stop TB strategy during that period. This slide repeat from what earlier I said. For the first stage, we already said the As you know, during that time, our TB service available only at the hospital. And the second stage till 2004, we expand to the primary healthcare level, the so-called health center. This slide just at the third stage, the stage from 2004 onward, we partnership with our NGO, civil society organization to implement community TB care and engaging a private healthcare provider in TB control. This slide just show the screening using mobile van at district hospital in the capital city of Phnom Penh. And during 1 year, about 1 year period, March 2003 till March 2014, we screen the total target population 1,735. That include people living with HIV, household contact with smear positive TB and a smear negative receptive TB. And among overall, let's say overall, we found from the screening by Chegre, we found around 11.6% diagnosed as active TB disease, and followed by around 4% is still TB suspect, 11% just after the heal image, and 9% other and normal approximate 64%. From this, if we look at the subgroup of the overall target population, we observe roughly around 60% at the bottom line. Among the smear presumptive TB patient that is screened, we detect around 16% as the active TB. Then this slide, just want to say about the population screening rate and the smear positivity rate for TB covering the period from 2001 till 2013, roughly around 12 or 13 year period. As you can see, our historical dot expansion started late 2001 till 2004, 2005. You can observe the population screening rate sharply increase, starting from 0.4% in 2001, and then to 2005, jump up to roughly around 1%, and then the trend of population screening still continue to increase. Our recent year stay around 1.1 or 1.2, something like that. If you look at the same time, if you look on the smear positivity rate, in contrast, start gradually decrease from the high level of around 29% in year 2001, and then gradually increase to around 0.6% 2004 to 2005, and this to 2005 yet the positivity rate stay around 15% or 16%, and then the rate still going gradually increase, like in the last few years, 2012, 2016, stay around 8%, something like that. The next slide, I will just summary about the comparison of our smear positive prevalence rate. This is the data from the previous national prevalence survey that I talked earlier. We conduct 2 times already, 2002 and 2011. You can observe in the survey the results smear positive in 2002 compared to the smear positive in 2011. We see around 56% reduction of the smear positive prevalent with symptomatic, yeah. And for the prevalence of severe positive without TB symptom, dropped by 8%. Overall, take the opportunity to inform all of you also between the two surveys within the 9-year interval, 9-year period. We review the prevalence by around 38%. That corresponds to approximately 4.2% per year. The prevalence of severe positive reduction around 4.2% per year. And the next slide, similar to that, the prevalence of severe positive also, but just for the previous slide is the prevalence of severe positive for age 15 and over. This slide connecting with the prevalence of severe positive, but for all age, not only adult. On the left side, it shows the result from the second survey 2002. On the right side, it the result from the second survey 2011. During the first survey, you can see the severe positive prevalence stay much higher, 270 per 100,000 population. This means that in the community around 100,000 population in the community, we have the prevalence around 270. And out of which they have the symptomatic, 165 in the first survey. If we look on the second survey, the prevalence that have the symptomatic, so the symptom drop drastically, just the rate 80 per 100,000 population. While on the blue color on the second survey, just so without symptomatic or less symptomatic or asymptomatic, more than the symptomatic. You can see 80 versus 85 among the prevalent in the second survey, total 165. This means that in the community, we still have the prevalence without a symptom much larger than the symptomatic one. Why in the first survey we have symptomatic a lot symptomatic in the around 2000? Because you remember before we expand the dot that before early 2000, we are difficult, challenging in terms of accessing services. When we start to expand the dot to all the primary healthcare around 2001 till 2005, we detect a lot severe positive cases. That's why in the second survey, 10 years later, we do second survey, we observe the prevalence of the severe positive drop down drastically from 270 to 165, as well as the symptomatic compared with without symptomatic. We observe asymptomatic is much more than the symptomatic.
Could you accelerate your speed of the presentation and finish in the 3 minutes?
Oh, yeah. I will.
Yeah.
So I just show all you will know about our experience in Cambodia. We do the active finding. This slide just show you the 3 model, pick up the 3 model, the so-called community-based active finding. The first model on the left side is conducted by the National TB program, focusing on the neighborhood and household contact of TB check, registered in past 2 years. And the second model focus on the poor population in the capital city of Phnom Penh, And the third model for target population focus on elderly people age 55 and over. And for the left side, the strategy to screen all the contact should be take CRA and then followed by the gene expert. For the middle, for the poor in the capital city, we do not use the CRA. We rely on symptomatic based screening followed by laboratory microscopy and gene expert. And for the third column, targeting elderly, we use the first symptomatic screening followed by the CRA and expert testing. Yeah. And roughly among the three models, the case they approximately not different. Yeah. This slide showing a good success rate of our teaching TB patient between 95 till 2019 cohort. The success rate ranging between 93 till 95. That's why we can bring the low rate of the TB as found in the three consecutive survey of national tradition survey. The first one, no or TB. Among previously case around 3%. The second one among you case 1.4, and among treatment case 10%. And the last survey in 2007 primary result so around 0.8% and 9.8% among previously treated. This just show you about the trend of AV0 prevalence among TB patient. The blue bullet is the data that taken from a program, and the red one is the data that conducted by National TB program 4 rounds already in the 2003, 2005, 2007, and 2009 from our survey. In 2003, sold around 12%, and then go to 10%, and the last one in 2009, the rate 6.3% AV positive among TB patient. And last year, in the last few years, we rely on our routine surveillance data from the NTP. From the routine data, the rate around 2.2%. So these are the last slide. Sorry. So from our experience, you see, we still have. It means we still have the smear negative predictive TB that is required using the CRA, and then that's why our future policy from the country NTP we would use the CRA as the screening tool, and we should pilot in some province, and then the intervention should be promoted and expand, something like that. And together with our current expansion of the rapid muscular diagnostic test, mainly using the expert. And the third one, our Cambodia NDP together with partner, we plan to conduct the third national TB prevalence survey planned in 2022, but it depends on the COVID pandemic, something like that. So thank you. This is all my presentation.
Thank you, Dr. Vanna, sharing the very unique experience of Cambodia to show the sharp decline of TB incidence and notification. So after the DOTS expansion, then our DOT decentralization DOT together with the expansion of X-ray service. So it's very unique, and thank you very much. So next, then my colleague, then co-chair, so Bintari, so we'll speak about her local experience at this time, not international or not national. So then including experience of CAD. So Bintari, please, then thank you.
Good afternoon and good evening, everybody. Thank you for coming to this session. I will share our experience on the chest X-ray screening among communities, high-risk communities in Yogyakarta in Indonesia. It is a part of the Zero TB project activities. So the Zero TB received a donation of QXR box from the Burnett Institute, who received the donation from the Cure AI, and then the utilization of the CAD is paid by the TB Reach. So the project is a collaborative project between the Faculty of Medicine of Gadjah Mada University, the health offices, and the Burnett Institute to eliminate TB more rapidly in Yogyakarta by applying the principles of Zero TB, the search, treat, prevent. So part of the search is doing the active case finding and contact investigation. We also do the screening for TB child TB in child health post. And then we support the treatment by the primary health center. And for the prevention, we provide the TB preventive treatment. The project started in 2020 by only 2 sub-districts. So the Yogyakarta province consists of 5 districts. And then we choose Yogyakarta and Kulon Progo district. And each district, there are sub-districts. So in 2020, we only work in 1 sub-district in Kulon Progo called Samigalu. And this is a rural sub-district, and a district in the city called Gondomanan, and this is an urban slum. Then in 2021, we start covering the whole city and the whole district of Kulon Progo. So the situation is different. Yogyakarta city is really urban and Kulon Progo is really rural, with the difference of area and the population density. Usually in the health system, we use the primary health center, and it will be called Puskesmas from now on. We have the gene expert referral center for each district. There are 4 gene experts for Yogyakarta city and 2 gene experts for Kulon Progo. In 2018, there was a modeling study conducted by the NTP based on the prevalence survey result to estimate the case in each district. So each district of Yogyakarta has about 1,000 estimated case, but the notification is still much lower, especially during the COVID-19 pandemic, that the notification was dropping really huge. So our activities of active case finding, we apply the chest X-ray and symptom screening, and then we select the population in the sub-village area based on the historical number of TB cases, decided together with the district health office, and each team conduct the active case finding for each district. We outsource the radiology service because we don't have our own X-ray machine. So inside the outsourcing, it includes the van, machine, driver, and the radiographers. And each Puskesmas area has 8 to 9 days of active case finding. So we really need to select the population. And during the pandemic, the maximum we can screen only 100 per day. And since 4th of May 2021, we use the QXR, the CAD software provided by Cure AI in Kulon Progo team only. So this is our algorithm. The STF received the invited participants and also referral from the household contact investigation. And then the symptom screening and chest X-ray screening was conducted in the chest X-ray site. And then those with cough for more than 2 weeks or hemoptysis or with lung abnormality will be requested to submit sputum, where we send to the gene expert referral center. And if finally they decide that they don't have TB, they will be reviewed for the TPT eligibility. So the participants flow is almost similar to the TB prevalence survey. So with the registration to get the identity and also to conduct the COVID-19 screening. And then they undergo symptom screening, chest X-ray screening, and then the doctor can receive the image or the CAD interpretation of the image. Then the X-ray, the sputum is taken in place. So how we do the community mobilization? Actually, it is the important investment that we involve the high level and local community leaders. So for example, we involve our governor, the Sultan, and then our mayor. And also we received the visit of the Minister of Human Development. So that one improved the mobilization of the community. We also conduct the village level multi-sectoral meeting before each cycle of ACF. And we involve the young community officer, young community worker to help mobilizing the people. We try to include as many as possible, also people with disability or elderly, but unfortunately with the X-ray van, we cannot do the X-ray to those who cannot stand up. Then we collaborate with the village leader to pick up for old person or with difficulty to reach the ACF site. And then when we conduct the screening in the prison, we don't discriminate the inmates and staff. And all staff sign the code of conduct to respect the non-discriminatory action. The Cure AI that we use help a lot because it shows the hot zone, and then it indicates whether the further TB examination is requested. So like this, and the score is not shown immediately, but we can download the score after. So when we did the screening only in 2 sub-districts, we actually cover almost 30% of the population. But I don't think it is as effective as if we just select the high-risk population. So we have higher rate of presumptive TB cases, but lower case notification. So during 1 year, including during the high peak of COVID pandemic, we screen about 13,800 people. But then in 2021, during 4 months, we already screened 12,800 and we select the population. Our doctors were more experienced, so they become more specific. So the presumptive TB case rate decreased. And also in Kulon Progo, with the help of the QXR, also the presumptive TB cases decreased to 10.8%. And we detect still a huge number of TB cases. So it's already double than what we did in 2 sub-districts only in 1 year. So this is the presentation by my colleague, John, in the INA-time, the TB conference in Indonesia. It shows that in this 6 puskesmas that we conduct the STF, the case notification increased compared to the same period of last year. So our challenge with this method is that when we screen the community, we have healthier patients because they don't feel sick. And our method with X-ray is highly sensitive. So as a result, we have risk of missing TB cases among the presumptive TB with negative expert, risk of overdiagnosed among those with previous TB treatment history because their gene expert may be still positive and the chest X-ray still showing abnormalities. And we have a huge number of presumptive TB cases that needs to be reviewed to be decided whether they have TB or not TB. And it increased the data entry and clinician workload. So we have to put more resource to do the case discussion panel. We need to fulfill the need for repeat confirmatory tests. For example, if we need culture, unfortunately for gene expert, we cannot repeat unless they are invalid because there is only one test for each presumptive TB case. The CAD with the score help improving the specificity of chest X-ray image. And then we provide support for data entry because of the high number of presumptive TB cases. And our national database open since they become presumptive TB. So there is a huge load to enter. And we have clinical forum by group, by WhatsApp group to decide or to communicate the clinical decision and other clinical issue. So our problem is more on this deciding TB among the screen positive and expert negative. If we see the number that we screen, this is only for Kulon Progo with the QXR. So we have about 10% of the screen positive but expert negative. And then most of them are in the group of only with suggestive X-ray without symptom. And this group 2 actually range from the small lesion to the very specific one that is easy to manage. But there are more and more the non-specific one because the community has maybe a subclinical or earlier stage of TB. So this is what we propose. If for those with symptoms and the X-ray normal, we just advise to seek care if the symptoms stay after 14 days. And then if they become negative and they are eligible for TB preventive treatment, then we have to start the treatment. The group 2 is the difficult one. So because they have huge range of X-ray abnormality, so we need to put priority. Those with high priority, we re-reviewed and maybe we'll need to repeat the X-ray in 3 months. And if in 3 months the X-ray doesn't get resolved, then we need to repeat the gene expert. Then the group 3, they have symptom and X-ray abnormal. Actually, they have higher probability to be diagnosed as TB. So we try to review, and then the second gene expert or culture if still symptomatic, but this one still difficult to do because culture is expensive, and the second gene expert we may not be allowed at this stage. So this is the presentation. So I thank you for everybody who support the project, the health offices, TB Reach, TB Prime, Burnett Institute, and Cure AI, and also the Center for Tropical Medicine. Thank you.
Thank you, Bintari. Then to share your local experience with us, and particularly then your categories of the result of the screening and the result of the program. Then so we'll discuss in the group discussion. Thank you very much for sharing. So I'd like to invite Dr. Sandra Kick, then a special speaker or invited speaker. So in this session, so then to share the recent development of chest X-ray and CAD with us. So Sandra, please then. Thank you.
Thank you. Can you confirm that you can see the screen, please?
Not yet.
Not yet. Okay, sorry about that. Share.
It came.
Yep.
Good work now. Okay, yes. Okay, so thank you for the opportunity to give a very brief talk here, and I hope I can stay within time. I have no conflicts of interest to declare. And I said I'm working as a consultant for FIND. And I will present here a few slides on some of the work that we have been doing on the evaluation of CAD software. So as has been mentioned already in earlier parts of this talk, and I think also we will be discussing that a bit later on in the workshops, the WHO has distinguished, and also I think in many of our programs, we distinguish two different use cases where X-ray is being applied, either in systematic screening settings where individuals are tested because this is provider-initiated treatment, screening, and individuals often do not have symptoms. In contrast to triage settings where people are presenting themselves to health facilities, and the reason to do an X-ray there is to differentiate, for instance, TB from other respiratory illnesses. It's important to distinguish these two different use cases, not only because the population, the target population is different, as I just mentioned, also the underlying prevalence of TB is different, and therefore the consequences or actually the question that you're asking from your chest X-ray is a bit different. So applying chest X-ray screening in either a facility will result in different positive and negative predictive values compared to when you apply X-ray in a screening setting. But it's also important to think of other differences in the infrastructure. So oftentimes in facilities, you can get away with a stationary X-ray equipment in a dedicated room, whereas in screening, you will need to search for other alternatives for your X-ray equipment as well. As part of the recent screening guideline that WHO has published, not only the performance of X-ray interpreted by humans was evaluated, but we also looked at the performance of different CAD technologies. And I'm presenting some of those results here. So part of this work has been done by FIND. And this slide shows the two different use cases that FIND assessed. We looked at three different CAD softwares, CAD4TB, Lunit, and QXR, which were the three softwares that were on the market and had received CE certification at the time when we did the evaluation. And we had a compilation of chest X-rays from triage studies, retrospective data from these studies, with a number of confirmed TB cases and individuals that were confirmed to be negative by expert and culture. And when we look at the performance of these CAD software and compared it with a human radiologist, which you can see is indicated in with the purple point in this ROC graph, you can see that even though the radiologist in our instance had a slightly higher performance than the different CAD softwares, this CAD software was able to reach almost the same sensitivity and specificity to detect active TB. The same exercise we also did for screening use cases. Here we had access to many more chest X-ray images. And also here we see a similar pattern that the overall performance of the CAD software was very close for the 3 products, and they were able to achieve almost a similar performance as the radiologist experts. And in the case of this study, the radiologists were very highly experienced radiologists, so probably not comparable to radiologists in the field who might have less experience. 2 other studies, and I have only highlighted here the ones that looked at triage settings, so where patients were either presenting themselves or were referred by a doctor to get a chest X-ray conducted, are highlighted here. In the left panel, you see the recent publication that was published by authors from Stop TB Partnership on a study in Bangladesh, where also they evaluated the performance of the same 3 CAD technologies as well as 3 other products, and also found that the software achieve a high accuracy. And when compared with Bangladeshi radiologists, even using different classifications, so either, for instance, calling all images with any abnormality or those with suggestive of TB only, the CAD products were still able to achieve a higher specificity compared to the local radiologists. Then lastly, another meta-analysis that was conducted by the McGill group. They pooled data from 4 different triage studies. Also there, they looked at the same 3 CAD software products, CAD for TB, LUNIT, and QXR from figure A, B, and C. And actually, they confirmed the same findings, that we can find a high accuracy of the CAD products. In this study, they did not compare it against the radiologist readers. Another finding across these different evaluations was that even though the CADs can perform well, we see that the threshold, so the threshold that you choose to indicate whether you should conduct confirmatory testing in that particular population that has a score above the threshold, sensitivity and specificity of the chosen threshold is different across different studies. So you do need some pilot testing in your country before you would be able to choose the best threshold for your setting. We see that this area of chest X-ray imaging, but also the interpretation by CAD products, is moving very fast. So we're now moving towards X-ray equipment that is more portable. The devices are becoming smaller. They're direct. They can take a direct digital image, which has great advantages for sharing X-rays, over longer distances for teleradiology, but also to combine that with a CAD interpretation. Earlier this year, FIND has published an overview of the different portable and ultra-portable devices that are on the market, which you can find here. Similarly, we see that the development of these CAD products is going very fast. So for the WHO screening guideline, we looked at 3 different softwares, but there's many others that are coming on the market and which are ready for evaluation soon. So together with the Stop TB Partnership, we're hosting this AI for Health website, which we try to update regularly to share with the TB field the status of of the different CAT products that are out there. So this offers you opportunities, but also challenges, because on one hand, you can choose the best product for your setting, whether you would like to apply chest X-ray screening in a facility, if you perhaps have access to uninterrupted electricity, internet connectivity. But it also has a lot of challenges, because you can mix and match the different products, but you also need to make sure that it's a streamlined solution in the end. So this brings me to my last slide, where I try to summarize, well, the advantages, but also some of the challenges that we still need to overcome when we think of increasing access for X-ray screening. So what we see is that CAT products are able to achieve a similar performance as radiologists, what was from the evidence that was reviewed by different groups. In areas where there is limited access to radiologists, this gives you the advantage of being able to increase TB case finding. In areas where you do have access to radiologists, CATs may increase the efficiency for the radiologist by filtering out all images that, for instance, would be normal and do not require further assessment by the radiologist. Another advantage may be that the threshold of the software is one that you can adapt. So you can choose whether you would like to be more sensitive and then carry out more confirmatory tests, or whether you're still, a suboptimal sensitivity would be enough for your setting. And you can also adjust that over time and monitor that. With the new ultra-portable X-ray devices, X-ray testing can now also reach other areas that in the past were not served for chest X-ray testing. So I think this is a great opportunity that we have at hand. But there's also a lot of challenges still. So I've shown you the variety of different products. So it's hard to see which product fits best. So this will be a thorough assessment that you have to do for your project to determine which product and combination of products would be best suited. Also, there's still a couple of technical challenges. It's not a magic bullet. It's not a point of care test that you can just take anywhere and start to use tomorrow. And also the investment costs are at the moment still relatively high. But hopefully in the coming years, these are all barriers that we can address and overcome in some ways. With that, I would like to thank you for your attention.
Thank you, Sandra, for the nice presentation and show us the possibilities of X-ray machine and the TAD availabilities. So the next presentation will be done by Dr. Rein Huben to replace Beatrice Frachella. And he will present the roles of chest X-ray for detection of TB and subclinical TB. You can start, Dr. Rein Huben.
Thank you very much. Can I confirm that my slides are visible?
Yes, they are.
Yes.
Thank you very much. So yes, as said, I'm presenting this on behalf of Beatrice Frachella, who couldn't be here because she's doing an exam for her master's at Harvard. So she sent her apologies. I'll try to replace her as best I can. So I will cover, I have no conflict of interest to report. So I'll briefly cover how the paradigm of TB disease is shifting and how that's relevant also for the subject today. Then talk a little bit about how much of clinical disease there might be and the potential of X-ray combined with CAS screening to detect it. So before we go into how we got here, a little bit of prehistory. So in the beginning of the 20th century, it was widely understood that TB operated on a spectrum, and this is reflected in the different terms used, for example, in the National American TB Association And if you asked any of the global experts, for example, here as explained, they would describe TB as operating on a spectrum across which individuals can undulate over time. And also in that period, mass X-ray screening was one of the main tools used to control TB, as is highlighted also in Japan and other areas, which led in what now, and was mostly applied to what now are considered high-income countries, but led to rapid declines in the burden of TB over time. But during the 1960s and 70s, that shifted, and the classic paradigm we've all been taught came to be. This was driven in part by treatment trials, which were either directed towards preventing TB disease or curing TB disease, driving this two states that we know about now. There was also reduced return on investment of mass screening, particularly in these high-income settings. It had seen a massive decline of TB over time, but now had to do the same amount of effort for fewer cases found. And there were also a number of case control studies that highlighted how the most infectious cases, severe positive, were actually also presenting with symptoms. And this led to the construction of the classic paradigm as we've all been taught it when we trained. And in turn, this paradigm then became the foundation for the DOT strategy that was rolled out in the 1990s. And in some ways, whilst it's been useful, it's also actually quite an unsuitable framework. For one, there's a large and mounting amount of evidence against this division of TB into latent TB infection and active TB disease. This has been reviewed very nicely elsewhere, but in brief summary, latent TB infection is neither lifelong nor is it actually latent. And active TB disease is not always symptomatic, and not everybody progresses directly from latent TB infection into this state. And finally, with regard to outcomes, for a long time it's been considered if you survive TB disease, then you would be fully recovered. But as people who treat patients in the field will know, actually a large proportion of individuals have long or even lifelong consequences from that fall on the post-TB. There's also consequences for policy in other areas, such as policy. While the DOT strategy has been very effective globally to prevent death, our current rate of decline in incidence means we might reach our global target somewhere in the next century rather than in the next decade. And for research, the consequences have also been quite substantial. First of all, there's been a number of very large, very expensive trials looking at community case finding looking for symptomatic cases, which have had either no impact or limited impact and mixed results. But we still are facing the consequences now. For example, in the past decades, there's been enormous investment both in human resources, some of the brightest minds of the working in TB, and also financial, to develop massive biobanks of samples to develop new prognostic or diagnostic tests using blood markers. However, these have all been calibrated towards symptomatic clinical disease, which means that when they then get applied to asymptomatic disease, their performance becomes a lot more ambiguous and declines. And we are risking also a similar issue in development of vaccines, which are excellent to have, but again, these are being tested against cases with clinical suspicion, i.e. symptomatic patients, which may not be the right way to go. So facing these issues, we can shift the paradigm to something that looks more like this, where TB disease and MTB infection are actually defined not by a certain test, but are defined by whether or not there's viable bacteria present and whether the bacteria are causing pathological damage. That means that the disease threshold might shift quite a bit down to where pathological damage has started to occur. And substantial phase of clinical disease is recognized, some of it infectious, some of it not infectious. And just as a side note, this non-infectious disease is now also referred to as minimal, or in the past as close TB. Now, just as to recognize some types of TB, extrapulmonary and the majority of pediatric disease, never become infectious, but can develop into clinical disease, which is what most reflects active TB, the classic active TB disease, with symptoms, infectiousness of pulmonary, and a risk of death. And then with the outcomes, we should also recognize in our new paradigm that some individuals do not recover, because that has relevance to that we might prevent some of that post-TB damage by diagnosing individuals sooner. And that is where the relevance for this workshop comes in, because in theory, or at least conceptually, the pathological damage caused by the bacteria should be detectable by imaging, and hopefully the majority of it by X-ray. So one of the big questions, and that's the one that Beatrice addressed in her paper, is to ask how much of this type of disease is out there. Now, this is work that built very much on the work done by Erwin Law, Ikushi Nozaki, and Catherine Horton, who put together the key bits of data. And what we did was to review TB prevalence surveys to find a consistent definition of subclinical disease, the burden, see what the burden was, and how different screening strategies might perform. So the review included 23 national surveys that reported the right data that broke down the results in the right ways for us to analyze and address these questions. 5 subnational surveys covering 23 countries and 36% of the global burden. But because of the variety of countries, it effectively covered the vast majority of global TB burden today. So with regard to the definition, we focused here on subclinical infectious disease, which still remains a target of the majority of global TB programs. But this is bacteriologically positive, but negative on symptom screen. Now, while a useful definition because it allows for quantification through the prevalence surveys, it's important to note that the definition of what is a symptom screen varies. It can be cough of 2 weeks, it can be a chronic cough, it can be any cough, or it can be cough in combination with another symptom. Although we found in the review that there was no particular trend visible. What is important is that the answer you get from a patient, from an individual, whether or not they are experiencing or aware of symptoms, will differ very strongly whether you ask them randomly on the street, after you've done an X-ray, and especially after you've diagnosed them with TB, which is a deadly respiratory disease. And finally, the definition of what is bacteriologically positive varies as well. Is it done by a smear, a culture, expert, or expert ultra? And how many samples and what samples did you use? It will all affect the value you get. But putting together different prevalence surveys, which are relatively consistent, we found that around 50% of the global prevalent burden of infection of bacteriologically positive disease was subclinical, without a particular, and we also know that there was no particular relationship between the burden found, as indicated by these crosses, and the proportion that was subclinical. Some additional work has been happening that links to this, is that of this burden of subclinical disease, for one, it can persist for quite a while. Some interesting work done by Chu Chang Ku and colleagues has highlighted that the period can quite vary. And this has been extended through a systematic review and excellent processing work by Alexander Richards to highlight that not everybody with subclinical disease will rapidly progress towards clinical disease and therefore report to a health center, but will either remain after 5 years subclinical or even regress after having been infectious for a period. And also a key question, are symptomatic individuals infectious? And work that will be presented at the Union conference will show that they are, and contributing substantially to ongoing transmission, making this a relevant target, again, coming back to this workshop to try and find. Our third objective that Beatrice had nicely highlighted is the performance of different screening. So less than 25% of the individuals would have been positive only on the symptom screen, whereas using an X-ray would have found at least 3/4, and in many of the different countries would have found more than 90% of the bacteriologically positive cases, highlighting the potential of X-ray screening. And as already been covered very nicely by the speakers before, the rapid technological developments in X-ray screening have trickled through to WHO guidelines, with now computer-aided detection software coming to the fore and help and maybe enabling more wider screening programs, given the often low availability of qualified radiographers in the field. So just a few more notes on to make the case for X-ray screening. If we consider, first of all, X-ray screening will enable us to uncover more of the spectrum of TB disease. And some very nice work by our host today, Dr. Okada, has shown, is that when they looked at individuals in Cambodia who had screened positive on X-ray 2 years previously, they found very high rates of progression. So with X-ray, you can identify very high-risk populations, which maybe should be considered for, if not full treatment, some form of treatment to prevent them from progressing. But it's also important to remember that in this spectrum, not everybody will progress. So you might find people that will never actually report to the clinic, but are contributing to transmission. With regard to the case for community X-ray screening, I've already highlighted before that in the past, mass X-ray screening has had substantial impact. But also more recent work outside of the ones already presented for Cambodia and Indonesia. This is work published around the work done around Karachi, which particularly highlights that using X-ray, we can substantially enrich the population we test with expert. And depending on the cutoff you use, the rate of X-ray positivity goes up quite substantially. And that links or would resonate very nicely with the work done by Beatrice. When it comes to clinic-based X-ray screening, there aren't many studies that have looked at this explicitly, but it seems to be something that is worth exploring. Work done on people with symptoms by classes and colleagues found that if they looked just at individuals with symptoms, they found that 5% of the population visiting the clinic had culture-positive TB, and with X-ray having a high sensitivity, that might even be expanded. And a recently published study, very nice work done in Blantyre by Peter McPherson and colleagues, shows amongst adults with cough, using an X-ray as using computer-aided X-ray screening as part of the diagnostic pathway, vastly sped up the process of getting individuals started on treatment, although they didn't find any additional cases using this approach. But both of these are focused on using symptoms as well. Using symptoms as an entry point rather than using X-ray as an entry point. So in summary, just to emphasize, it is useful to let go of the idea that there's only one state TB disease, but it actually exists, but accept it exists on the spectrum. And as a clinical disease, so not where people are not reporting symptoms, accounts for about 50% of prevalent TB in the population. It is infectious and can persist for long periods, so it is worth addressing. Using X-ray should be able to detect more than 75% of all bacteriologically positive disease in the community. And while WHO screening guidelines have moved, I think we do need more test cases to see if clinic-based X-ray screening could have a massive impact. We have seen that symptom-based clinic screening has a high potential, but it'll be interesting to see what X-ray plus CAD screening could achieve. And I think that's some discussions we're going to have in the breakout rooms later. With that, I want to once again thank Beatrice for doing some excellent work. I hope I did her work justice. The group at London School and the funder and the organizers for inviting us to speak. Thank you very much.
Thank you very much, Dr. Rein. It's very important presentation because it helps us understand the new paradigm of the spectrum of TB disease, that now we will find more and more subclinical TB either in the clinic or during the screening in the community. The next presentation will be done by Ms. Kins Eyman, and she will present the performance of ultra-portable X-ray and CAD from the experience in the field. The floor is yours.
Just to confirm, is my screen visible?
Yes.
Okay, great. So I'll be sharing the experiences from the field of Pakistan on the performance of ultra-portable X-ray and computer detection. My name is Kenzu Liman and I'm working in Pakistan. I don't have of interest to disclose. So X-ray is a device from Fujifilm, Japan. It's a super compact digital X-ray machine and is relatively easy to use and handle with CAD software that was through a separate laptop. A diagnosis with this edge-cutting technology, the PASI has been able to achieve a good image quality, less radiation, and ensuring provision of diagnosis in most hard-to-reach areas of Pakistan. The PASI's intervention that was supported by a Stop TB partnership under the TB initiative marked the first time that this particular device was deployed for TB screening anywhere across the globe. Before XR or this ultra portable device being introduced in Pakistan, we were using the mobile vans, which obviously had limited access due to the poor road infrastructure that we have in Pakistan. XR provided an ultra compact solution. The XR itself weighed around 3.5 kgs. It had a DR console and a separate laptop for the which was carrying the computer detection software. And we could take around 70 to 80 X-rays without without any kind of electricity as well. The dosage, though, was very less, but the image quality was reported to be extremely good by the radiologist, like the trained radiologist in the health facilities. And the X-ray itself was very compact and lightweight. So I'll just show a couple of videos to sort of show the areas where this particular device actually enabled screening. So this is a video from the Lakra area of Sindh province that does not have any kind of health facility or any kind of even electric supply. This is how the device was actually, this particular device is actually set up. So we used XR equipped with CAD for screening coal miners in associated communities at the coal mining sites. We targeted at screening around 14,000 coal miners and associated mining community members. Alongside, we were running the X-rays on Lunit Insight CXR on the site, and retrospectively, we have obtained readings on QXR as well. Till date, we have screened around 14,000, identify around 125 TB positive cases in these hard to reach coal mining site areas. This is another video from a particular coal mining site in Punjab province of Pakistan. So this was the first time that we were actually able to, the huge mobile vans and everything, we were not able to get access to these areas, because certain areas, for going to certain areas, you have to actually go through cable cars or actually hike for a couple of sort of kilometers. The device was further used for COVID testing as well. And we have screened around 1,500 individuals with the XR followed by PCR, and the results of this particular study are still being analyzed. So we showed the device alongside the results of the screening to the national authorities and the provincial authorities, and have received certain testimonials on the portable X-ray and the artificial intelligence detection that was being used, and I'd like to share that with the group.
TB is still a high burden disease worldwide. Globally, 10 million people fell ill with TB every year. In Pakistan, the incidence of TB is 580,000 new cases every year. Pakistan is fifth among the 30 high burden countries. The Global Fund Stop TB Partnership are leading the innovative screening program in the country with the support of the local NGOs like the Pasi Foundation. We primarily use photon microscopy for the screening purpose, but it scales. Really, we also use PCR or gene expert, which is very expensive for a resource-constrained country like Pakistan. X-ray was an ideal tool for screening, but X-ray is a heavy machine and requires a lot of power supply. And mobility is also an issue, and also requires a radiologist to read the images. QLNeozyre is an innovative machine. It is a super compact type of X-ray, weighs about 3.5 kilograms only, and it's battery-driven. It is equipped with artificial intelligence that has the capacity to suggest the TB suspected area and can be used in remote and difficult to reach settings. It hardly takes 10 to 15 seconds for an image to be taken and transferred to the unit inside X-ray artificial intelligence system, and the finding of comprehensive report on the 10 indicators, which are like nodule consolidation, pneumothorax, atelectasis, calcification, cardiomegaly, fibrosis, mediastinal widening, pleural effusion, or pneumoperitoneum. And it claims the accuracy of 98%. So far, our study experience has been exciting, and we are looking forward for promising results and further expansion of the intervention beyond this pilot study.
This era of technology, we are now having more innovative ideas about the diagnosis, and now have a special technique which is called as CalNeo X-ray machine, which is a sort of very innovative machine, and it may solve the purpose of a radiologist, and it may help for early detection of tuberculosis. Advantages of this X-ray machine: number one is that it's a very lightweight machine, and it has got a dedicated software. Through artificial intelligence, we can diagnose that this person is having tuberculosis. It has got a very high accuracy rate, and very small findings which are basically the subject biased and depends upon the expertise and skills of radiologists. I think this machine is able to detect those findings within minutes. So I think it's going to be a great idea to have this machine, and it has called unit inside chest X-ray artificial intelligence software, and it is detecting some of the findings on the basis of which we can find out that this person is probably having tuberculosis. Since this X-ray machine is very lightweighted, and it can be moved to far-flung areas where actually the portable machines, which are heavy one, they cannot be reached, I think diagnosis. And another thing is that in this machine, by using this machine, there is a very minimum exposure to radiation as compared to the conventional thing. Another very important thing is that we are having a lot of missing cases of tuberculosis, especially in the far-flung areas, just because of the fact that we cannot mobilize our resources to these areas. So this machine is a handheld machine, and it can be carried to all those outreach areas where huge X-ray machines cannot be taken, where the facility of radiologists is not available. So I think it's going to be a revolution in the diagnosis of suspected cases.
Just like to comment on the CalNeo X-ray technology. I've just had the privilege of having a go through of that. I think it's got excellent digital imaging in it. The quality is very good, and I would really like to advocate this and encourage my other researchers and colleagues to use this technology and go forward in diagnosing not only TB, COVID, and other such chest X-ray related abnormalities in which they can go to far-flung areas and benefit people who do not have access to facilities at tertiary health center.
So our study was presented to various national authorities here in Pakistan as well as internationally, and the results have been quite promising. And because time that it was implemented in Pakistan, the authorities, the radiologists, and everyone was quite amazed by the technology, and they are looking forward to expansion beyond the pilot stage. That's it. Thank you so much.
So thank you very much, then King Zeman. So then we'll have break session. So break and before Q&A. So Caroline, could you announce?
Yes. So we'll break for 5 minutes. I recommend that you do not log off from the Zoom meeting, though. You can just turn your video off and mute yourself. And I'll display a countdown slide for your convenience. We will resume in 5 minutes, so at 2:50 Paris time. Thank you. Welcome back. The course will now resume.
Thank you, Caroline. We will start with the Q&A. In the chat, we already managed to get some questions. So within 15 minutes, we will try to explain. We try to answer the 10 questions. So I will read loudly the question. The first question is from Mr. Heman Bogati for Jata. I guess this is for Dr. Seya. In your opinion, for incarcerated and high-risk population, will the yield of chest X-ray be optimal, or more accurate diagnostic tools such as expert MTB RIF could be used to conduct mass screening to make it cost-effective? Please,
Yes.
Dr. Seya Kato.
Yes, no, I think optimal yield from the screening is depend on the condition of the society, country or area. For example, in global country, we started to implement the screening for pre-entry screening. The expected yield is only 0.2%, but considering the prevalence of the TB in such lower country, such low yield is still acceptable. As for Japan, in the initial yield was 0.7%, which I think is acceptable. And actually, in 1964, the WHO issued the negative recommendation for massive screening in 1964. But in those days, the Japan experiencing the 10% decline in incidence in those days. So the policymaker in those didn't think of stopping the screening. And again, in 1964, the WHO number 9th committee issued a negative recommendation again. But in those days, Japan was already become economic expansion. So the policymaker again didn't think it's fit to the Japanese situation. So anyway, the yield is not only the factor to assess the efficacies of the screen, but also the follow-up with the people who are detected through screening. That is to how we increase the treatment outcome, how we get the favorable treatment outcome is also very important to assess the efficiency of the screening. Thank you.
Thank you, Dr. Seyakato. The next question is from Reinhuben to Dr. Tieng Savana. And also to me, is the same question. What is the definition of smear negative presumptive TB? Do these individuals need to have reported or presented with symptoms specifically for the X-ray screening activities? I let Dr. Sivana to answer first.
Thank you. Thank you. For that question, we mean smear negative presumptive patient. It means in the initial step starting from the presumptive TB case, and then one day we reach the health service, either the passive case finding or active case finding. After that, they go through the laboratory examination. In the case we refer during that those period, we examine by smear, and then the result, the smear, but the clinician still suspicious. The TB suspect, the we call the smear negative presumptive patient. This have to give the high priority further undergo to take X-ray examination. This is what we mean. Thank you.
Thank you, Dr. Sivana. So actually the presumptive TB cases is the participants of the screening that we asked to submit sputum for further examination, and the definition is varied among areas, among countries, or also among the population that we screen. So for example, in our project, the presumptive TB patients is those with symptoms or the X-ray abnormality. So can be only symptom, can be only X-ray abnormality, can be both, and they are requested to submit sputum. The next question is from Felix Mboya to Dr. Sivana again. This is important question. What is the cost of door-to-door TB screening? Can be this replicable? Dr. Sivana, could you answer again?
Thank you so much for that question. This one, it mean to my understanding, the question regarding to the three model might be the three model of active case finding, the so-called committee by active case finding. The first model targeting household contact with smear positive TB within the last 2 years, has to invite for screening. And the second model, it might be your question, is the target population is the people, the poor people living in urban area, and then they go door-to-door screening, this one. And from that, I said during my presentation, this model, the door-to-door screening focusing on the poor area. We've seen, I remember 12 months, around 10 to 12 months in the year 2013. In the year 2013, they screen approximate around 300,000 poor people, and then out of which they identify the symptomatic, suspected symptomatic, 12,201, something like that. Finally, they detect the case. 737, and the cost roughly, the strategy, this model approximate around 250 US dollar per case identified. It's a little bit cheap compared to the other model targeting the elderly people, and the other targeting the close contact. The cost per case approximate around 300 US dollar per case, but the door-to-door cleaning, the cost a little bit lower, around 250 US dollar per case.
Thank you, Dr.
Yeah.
Sivana. So it depends on the population that we select. If they are high risk, maybe the cost to find a case become lower. And the door-to-door screening, they use symptom screening, so maybe the cost can be lower than if we do the chest X-ray screening. So after is the questions for me, so I try to explain rapidly. So for the gold standard of the diagnosed TB, chest X-ray or sputum, the gold standard is still sputum. So that's why the chest X-ray is only for screening, not for diagnosis. Then after they are screened positive, then we ask them to submit sputum for confirmatory tests with gene expert. So I think it should be clarified that the chest X-ray here, the position is for screening. And then for the latent TB infection, we consider latent TB infection when they are excluded from the active TB disease. So if they are part into the population that we have to provide TB preventive treatment like household contacts or PLHIV, then we do further tests to test the LTBI. For example, the tuberculin skin test. And for PLHIV, we don't do the TST. We just start the TPT if they are eligible. Then the question about how do you find your target subject? Do you include all people in the selected neighborhood? So this is important. We select the level of sub-villages. So in Indonesia, we call it RW. And it is decided together with the primary health center based on the historical number of TB cases. So where there were TB cases in the past in that sub-village, then we invite everybody in that area to participate in the screening. The question from Rain has been answered. Then the question about the LTBI, I think I already answered also that we review the LTBI for those that exclude the TB disease. Then there is a question from Andre Dadu. Please describe the screening algorithm among migrants and develop a bit more on the TB care coverage among undocumented migrants and refugees. So who can answer this question? Dr. Onosaki? Can you join already or you still have trouble with the computer?
Yeah.
Yes.
So actually, this is a very important question, but a bit out of the scope of this today's topic. And just last week in IOM, or 2 weeks ago, the IOM organized the web conference webinar. So by this topic. So then I recommend you then to contact the IOM site. So as well as the union has the working group, I'm also the member, the TB among migrants. So then, so several documents is available then. So please consult them. So because then this is out of scope of this workshop, then so I'd like to skip because it is really very long discussion unnecessary. Thank you.
Thank you, Dr. Onosaki. Then the next question is from Irwin Low to Rain. What can you tell us about the infectiousness of people with subclinical TB? Can Rain answer the question?
I will try. I mean, first of all, there's just to recommend everybody come to the union meeting and join John's Emery's presentation that is there that will explain in great detail. In summary, what we did was reanalyze very nice data from the Philippines, Bangladesh, and 2 studies in Vietnam to look at what the household infection prevalence was and see if it was how it was different between patients diagnosed in the survey with clinical disease, so with symptoms, and individuals with subclinical disease without reporting symptoms. And what we found is that the difference is not very large. And that the same amount of household contact members are infected, regardless of whether the individual was not reporting symptoms. And that's what then that's reflected in the figure I showed with the relative infectiousness and the contribution to transmission, which means because if they are roughly equally infectious, that means that if half the population is subclinical, that means that around half of the transmission that's currently happening today is coming from subclinical individuals. There's quite a lot more details, but that's the broad summary. So it's looking at household contact studies, the same things we've used to establish how smear positive is more infectious than smear negative, for example. Hope that answers your question, Erwin.
Yeah, thank you, Rain. It's clear enough. So I will just allow one more question because of the time. So another question, because it's important, what is the experience of CAD in childhood TB? Maybe either Sandra or Kintel-Lelman can answer the question. About the CAD in childhood TB.
About what?
CAD in childhood TB. Or maybe please, Sandra, if you
as
have
per WHO guidelines, CAD and CXR aren't recommended below 15. So we were in our study in Pakistan, we have not been screening childhood TB using this particular experience CAD. Sandra might like to add something to it.
I actually copy what you said. It has not been evaluated. There's not a lot of evidence at the moment, but it's an area that has been pointed out as much needed for further evaluations. And also we know from CAD developers that this is an area that some of them are working on. But there's not any evidence at the moment.
Okay. Thank you, Sandra and Kins. So because of the time, I stop the Q&A session here, and we will go to the breakout session. So I let Dr. Onosaki and Dr. Okada to lead the session.
Thank you, Bintari. Then Dr. Okada then will brief about the breakout session. Dr. Okada, please.
Yeah, before me, the Caroline has some announcement.
Please. Just couple elements on the breakout. So for the next 25 minutes, participants, you'll be working in groups in breakout rooms. You will be automatically assigned to a group. Specific instruction will be provided by the moderators in your respective groups. Note though that you will get a pop-up window that's going to appear. You need to accept the invitation to join the breakout group in order for you to go to the right room. We encourage you to turn on your webcams and to be as participative as possible. Dr. Okada, if you want to add anything else prior we open the room.
Thank you. Let me explain how to proceed with the breakout sessions. As Cassie mentioned, I will divide all the participants into 5 groups to discuss 3 or 4 questions in each group by using the template which I prepared. As you can see here, I'm taking these 6 questions to be discussed in the sessions. However, due to the time constraints, you don't need to do with all the 6 questions. Some groups will discuss questions from question 1 to 3, and some question 4 and 5. If you have more time, please discuss question 6 as well. Group A, B, and C should be under the condition of community outreach, in which you go into the community with chest X-ray. And group D and E be under the condition of health facility with chest X-ray. As I explained in the next slide, there may be many subjects to or target for chest X-ray to detect TB. So for group A, B, and D, which will discuss question 1, what subject to be targeted for chest X-ray? You can select your subject from WHO recommendation, or you can decide your subject, which you may meet the WHO recommendation. As you know, WHO strongly or conditionally makes recommendations for population targeted for chest X-ray. Population strongly recommended by WHO household contacts, a person living with HIV, and so on. Conditionally recommended ones are urban poor, homeless, and other vulnerable groups, or people with TB risk factors who are seeking health care in settings with more than 0.1% TB prevalence, such as malnourishment or diabetes mellitus. In addition, WHO also conditionally recommends general population with more than 0.5% TB prevalence. So you can select your subject from these recommended populations, or you can create your specific subject or groups which meet the WHO recommendations. For example, other groups at risk who are seeking care and have more than 0.1% TB prevalence, or some populations who have more than 0.5% TB prevalence in general. I will provide this slide for group A, and B in community outreach settings to discuss question 1. You can select your subject for chest X-ray from these populations, or decide your specific subject to meet the WHO recommendation. Anyway, you should select or decide 2 subjects in question 1, and then move on to the question 2 for these 2 subjects. So I will provide this slide for group D in health facility to discuss question 1. You can select your subject for chest X-ray for these populations, or decide your specific subject to meet the WHO recommendation. And then you can move on to the section 2 for these 2 subjects. The group A, B, and D, I'd like to ask you to select 2 subjects which you took from the previous slide and discuss how, where, and who to approach such two subjects here. For group A, B, and C, D, please discuss who covered such chest exhaust, for example, by Global Fund or Ministry of Health, blah, blah, blah. So group C and D will start your discussion with this slide. I'd like to ask you to share your experience in chest classification, for example, active TB, healed TB, other lung disease, etc. For group C and D, please discuss what next step to be taken in each case if its bacteriological test was negative. There may be some options, for example, a recommendation by for TB treatment or just follow-up by chest X-ray. So for all groups, if you have enough time, please discuss question 6. Though we can not always find correct answers because it is not easy to carry it out. This is the question 6. Okay, so at the beginning of the breakout sessions, you will select these persons from your group members. After the breakout session, I will ask to make a report for each group within the few minutes. And if you have no questions, move on to the breakout sessions, please.
Okay, you're gonna see a pop-up that will tell you to accept the invitation to be moving to a breakout group, and
So
you're going to be assigned.
Dr. Okada, can I?
Yeah, it's okay. Caroline.
Yes, yes.
Do they recognize which group? Group A, B, C, or group 1, 2, 3? Group
No,
A,
it's
B,
going to be the name that you provided. Group A, B, C, D.
Okay, thank you.
Yes.
Okay, so Rain, please.
Just to confirm, how long do we have? And
yes.
when do you expect us back?
No.
We have set up 25 minutes. But
is that still the right time, given that I don't know where we are time-wise?
We're a bit behind, but we can, maybe we can shorten some other areas. It's up to you.
So how should we? 20 minutes or 25?
20 minutes.
25.
Okay.
It's
Can I say
right.
20 minutes?
Yeah, may skip question 6 then. Yeah.
Okay. Okay, thank you. So I give the 20 minutes to all participants. Thank you.
Okay.
So the groups are set up, and I've put 20 minutes at the end of, in 19 minutes, you will have a clock that shows you that there is 1 minute left to let you know that it's almost the end. I will now send you in different rooms, and we will see you afterwards.
All the room have been closed, so all participants are slowly coming back to the plenary sessions.
So welcome back. So I found that I visited a few groups during the breakout session, and schedule was so tight. So I'm sorry for that then. So due to time limitation. So Dr. Okada, then could you lead the discussion or presentation?
Okay, so yes, it's very short time to discuss, and maybe many group didn't have enough time to discuss. Okay, so shall we start with the group A? Group A.
Yoshi, would you? Yeah, Dr. Yoshi, would you mind share the PowerPoint? Thank you. Just in short, that we have a very fruitful discussion, but we don't have a chance to move on whom to cover the spans. But well, I'll try. We have many friends from many places, and from Malaysia, the doctor mentioned about the prisoners and also the refugees. They have many refugees, and before they can sent back to the other places, they have a chest X-ray screening program. However, for those refugees that are not in a special camp, or they are not there, they really have difficulty to approach them. So he mentioned about that. And for a friend from Turkey, they would like to provide some target groups to do contact investigation, and they have special local level TB dispensers that they can provide TB care. So they would help to do contact investigation, for chest X-ray screening for contacts, and they also send mobile vans to urban poor homeless people, and also to prisons to do chest X-ray screening. For Myanmar, they also have strong mobile team, and they have symptom and chest X-ray screening provided by local health authorities. They will aim at the inmates in urban pools. So they already sounds like they already have a established program there. And for Indonesia, that they share that they would like to refocus on the number one prioritized groups, which are people living with HIV and close contacts. Originally, they follow the close contact age less than 5 years, but now they try to expand it to all age groups. However, because in the culture, they still need to face the stigma from TB diagnosis, because when you use chest X-ray screening for contacts of people living with HIV, you will find some active patients there. And also, after screening negative, so you need to do TB preventive therapy. It's like they still encounter some explanation problems, just like a lot of countries. And they also have mobile X-ray for prisons. Next. So for Philippines, the friend from Philippines mentioned about the urban pool. They have a fairly high prevalence, although we cannot name it, but friends from Philippines said that could be very high. And also some of the areas that in prisons, some prisons could be very high, up to like 30%. I guess there are huge outbreaks there because it's very, very crowded. In summary, the Malaysia and Philippines program and Indonesia mentioned that the targets has been covered by government, but I don't have too much chance to ask to the details about whether they are the other part of difficulty for funding. But I think there's always there. So I think especially those hard to reach, people that we really want to approach, but they didn't come to our program. Why? Maybe because what we provided cannot combat or overcome the stigma, or cannot overcome the transportation difficulty or something. So we need to outreach them. Yeah, that's from our group. Thank you. So the time is back
thank
to
you. Okay, thank you,
Dr.
Anita.
Okada. Yeah,
Yes, thank you, Anita.
you.
Okay, next group B. Group B is who? Vanna or Kent from group B. Please.
Keen,
Okay.
please, Keen.
Dr. Swana, you can go ahead with the with reporting.
Please, Keen, please.
So we discussed the subjects that we targeted for with the priority was household contact, people living with HIV, minors, and prisoners, and urban poor, homeless, refugees, and migrants. And in terms of approach, we discussed that a systematic approach should be followed with the national guidelines, WHO guidelines, and the national algorithms available. For the slum areas, we discussed aspects in which active case finding can be done through portable X-rays alongside computer, by obviously the bacteriological examination or whatever the national guideline says. For homeless, we discussed homeless congregations through active case finding using and CAD. For social contacts, symptomatic screening followed by CXR and bacteriological examination. For household contacts, straight away bacteriological examination, maybe followed by X-ray. For prisoners, active case finding through CXR equipped with CAD, maybe through mobile vans. And then for mining sites, preferably portable X-rays, routine screening for people living with HIV at the Sentinel sites. Then we discussed who should be covering such cost, and there was a mutual consensus on that because these are quite vulnerable groups, the cost should not be out of pocket and should not have catastrophic impact on them. And the sort of institutions that were discussed were either the National Program, Ministry of Health, Ministry of Social and Labor Welfare, the government itself, and corporate social responsibility funding may also be explored from the corporate sector. We were unable to actually proceed to question number 6 due to time limitation. That's it. Thank you so much.
Thank you, Kent or Emma. Okay, so next group is the group C. Group C is Agatha or Bintari?
Yes, could you present, please? Okay. Yes, do you want to present?
I think you better. You're best at it.
Yeah, thank you. Actually, the X-ray classification was divided into abnormal and normal, and then with the CAD, it also provides the TB screening advice or not advice. It means the further examination should be done or not. And also for those abnormalities, there are classification of the type of abnormalities, consolidation, nodules, etc. And there is also suggestion of classification by location, but the chest X-ray actually target the chest. So with chest X-ray classification, it's difficult to say pulmonary or non-pulmonary unless it is a miliary appearance. Maybe there is a classification based on the location in the lungs, right upper lobe, etc. And then also the proposal to consider the TB symptoms when we check the chest X-ray abnormalities. Next. So what next step to be taken if its bacteriological test was negative? So it was the problem I raised in the presentation. So the participants of the group proposed that the next step depends on the accuracy of the bacteriological tool. For example, GeneXpert or culture has higher accuracy than smear, so we should use the most accurate tools. And sometimes in some area there is no access to culture or other more specific TB tests, or sometimes it has more access to the molecular tests like expert. Then there is proposal to do the comparative reading of chest X-ray. So this is done in several settings that the chest X-ray can be also interpreted by radiologists to compare. And then for children, the chest X-ray can add, can help the diagnosis, but also for children, we have to consider many other things like symptoms and other parameters like household contacts, etc. So that's the report from our group. Thank you.
Thank you. Thank you. So, next, group D in the hospital settings. So, Dr. Irene Lowe, can you?
Yes, okay. Okay, you can see my screen, Dr. Rickard.
Yes.
Yes, so thank you. In view of time, we just mostly just focus on one question, essentially, what subjects to be targeted for chest X-ray integrated, chest X-ray using the setting of an integrated health facility. So we had participants from Nigeria, Philippines, and India who offered some of their experience and from their health facilities, I guess, or their in-country experiences. Specifically in Nigeria, one gentleman told us about their diabetes clinic and that by using chest X-ray and to a certain extent expert, they could increase their yields of finding more TB cases from about 11 to 16%. He said it was relatively efficient and there was some sort of cost efficiencies as well. However, some other clinics like a malnourishment clinic, primarily for, I guess, for children, the yield was not as efficient. And someone mentioned, I think it was from someone from Nigeria, said maybe it's something to do with access, the cost of transportation, how do we get children to be screened? And I think it's partly related to someone asked this question as well, in terms of we need more evidence, essentially, in terms of the actual yield for these particular activities. In the Philippines, one lady told us that they're undertaking screening activities for COVID in particular health settings using chest X-ray, and also some of those with symptoms and using expert to confirm, and it seems to be relatively successful. They're also focusing on those of particular subgroups as shown there. A lot of this is covered by health insurance in the Philippines called PhilHealth to cover the chest X-ray, but sometimes the employer or the private health insurance or sometimes even out-of-pocket payment is out-of-pocket payment is done to cover these chest X-rays and some of these screening activities. And two colleagues from India told us that yes, these vulnerable group screenings are actively happening in prisons and urban slums, sometimes using experts, sometimes using microscopy. But importantly, one person mentioned that it's the challenge of using chest X-rays in rural areas where probably most of the population lives. So cost and access is still one of the biggest hurdles to getting any sort of chest X-ray integration in health facilities underway. So he said, yes, how is this to be paid for? What should we be using like mobile units? Should we be encouraging MOUs with governments and so forth? So I think what I get from our very, very brief 15-20-minute discussion was essentially you should publish a lot of these experiences. You should be talking about these experiences and getting the message out there, because you need to show evidence for an effect or not an effect. And then by only using this sort of evidence that we can eventually convince the governments and donors to hopefully pay for some of these particular screening activities in the future. I'll leave it there. Thank you.
Thank you, Ring, for a good summarized presentation. Okay, so last group is Group E, hostel settings. Okay, so who will report from Group E?
Yes, I will.
Kema. Okay, thank you. Please.
Can you see my presentation?
Yes.
Yes, so our group discussed about the classification on chest X-ray. We have participants from Indonesia and also Ukraine, Libya, and Lesotho. So from the Indonesia, the classification is overall normal and abnormal. And for the abnormal, further divided into LAN, cardiac, and TB-related abnormal. So for the TB-related abnormal, active BTB or HE, etc. So other Ukraine, Libya, and Lesotho, they also have similar classification. So for another question, next step to be taken if radiological test was negative. So chest X-ray suggested of active TB, they will perform gene expert, and if expert negative, repeat expert if possible, or maybe start TB treatment after clinical diagnosis. It may negative sputum, negative expert, but with strong clinical symptoms. So doctor, based on the clinical judgment, they can start TB and follow up accordingly. For HIV negative, maybe they can try with antibiotic for 10 to 14 days, and then after that, recheck X-ray. So for chest X-ray suggestions of inactive TB, without any TB treatment, there will be no treatment. So for the next question, so there's a participant from Indonesia share their experience. They also have a research on active case finding. So for the TB detection in COVID era, by doing contact investigation to TB household contacts, and also participants discuss about the integrating TB and COVID-19 screening in our community case active case finding, so that stigma may be reduced, person feel they can talk about their condition, etc. So this is what we discussed. Please add if I miss anything. Thank you.
Okay, thank you, Dr. Kema. Yeah, only your group reached the question 6. So very good discussion has been made. Okay, thank you. Yes, I can summarize all, but yeah, there are many countries which are implementing the community-based active case finding by chest X-ray, and some countries are implementing the some high TB screening for high risk at critical settings. Like Nigeria, yeah, they screen the patient with diabetes mellitus for tuberculosis. So yeah, due to the time limitation, if possible, I wanted to discuss more about such a collaboration between the TB and other component of the hospital. Okay, thank you very much. So now, yeah, nearly finished time. So Dr. Onoze, can you move on to the Q&A session in the remaining time?
Yes, thank you, Dr. Okada, to have the report back session. So due to the time constraint, so I'd like the 6 speakers to have some burning comments or last comment or some, if you have any burning question to the presentation from the group, that is fine. So otherwise then, could you have one comment each, then as a last comment to deliver home then today for the participants. So can I start from Dr. Kato in order, according to the presentation order? Any final comment? So after all discussions. For home delivering message.
Home. But anyway, thank you very much for all the participants. The time was limited, but we could share experiences and have a very nice discussion. So anyway, it's we have to increase case detection, and screening is one of the most powerful tool, and also innovative tool make us possible to obtain more fruitful outcome. So, but we have many things left behind to discuss. So we really expect to continue a discussion, taking advantage of these opportunities. Thank you very much for that's all.
Thank you, Dr. Kato. Yeah, thank you, Dr. Kato. Then next time, Ivana, Dr. Shibana from Cambodia. Any last comment?
Thank you, Dr. Ono. As you see, Cambodia NEP has achieved a great result over the past 2 decades. They are leading the Cambodia out of the 30 higher burden country with TB. However, we still have a number of missing cases to our estimation. At least around 1/3 of the incident cases still missing or undetected. That is very crucial that we work together to find more the missing case, either to meet the target of ending TB by 2030. Thank you so much.
So I'll ask Bintari at the last, then Sandra, could you have some last comment? Sandra? Yeah.
Sorry. Well, thanks a lot for organizing this session. It was very inspiring, I think, for me to see both historical evidence for chest X-ray screening, the country experiences, and now also presentations from the more modern and newer ways of applying chest X-ray imaging and reading with CAT solutions. So I really like to thank the organizers also for putting this session together and well, share with this whole broad audience all those different aspects of chest X-ray screening. I think we can all learn from all those different examples that were given. And yeah, let's do what Erwin recommended us, publish, share results, and see where we stand next year. Thank you.
Thank you, Sandra. Then Rain, could you please?
Thank you. Yeah. Again, thank you for organizers. Thanks for one session. And I would really second also Erwin's call. Like there's some very interesting data presented, if only from early memory, from Cambodia, from Indonesia, around symptomatic and asymptomatic and what X-ray screening is doing. And there are some beautiful papers in there that would be lovely to see them out. Yeah, I think working through that would be excellent. Thank you very much, everybody.
Thank you, Rain. Then Kins, please.
Yeah, I'll just thank everyone for joining. Thank you to the organizers for putting a very well organized session together. And obviously portable x-rays and computer diagnosis is now the future. So more publications should come through, more support on how to sort of calibrate the the AI softwares, the CAD products into the local context is, I suppose, what is needed for the future. Thank you so much, everyone. Thank you. Bye.
Thank you. So my co-chair, Bintari. Thank you very much for your contributions.
Thank you, Ikushi. Thank you, everybody, to attend the session. So actually, I learned a lot also from the other presenters, and the example for countries that that has been successful to decrease the TB prevalence and incidence with the systematic screening. So there are already examples, and we're just doing what Japan has done in the 1950s, for example. So I think it is feasible, but then when we are getting closer to eliminate TB, it will be more complicated and expensive also to find the case and to interpret the TB case. So I hope everybody get the nice exposure of the activities and the challenge. Thank you for all.
Thank you, Bintari. So as a president of the chair, so I'd like to mention two issues. One technical issue is TB with, old TB or HEAL TB without treatment, like fibrosis and calcification. So in new WHO guideline of systematic screening, they are the target of the systematic screening. But community screening and the screening by medical setting may detect those chronic or old TB healed cases or fibrosis. So the US and Japan and European country, they are one of the priority target of the preventive therapy, right? And in WHO, it is actually follow-up target of the systematic case detection. But actually how to manage in the field is a big challenge. This is one issue. We still need to learn a lot and pilot and hopefully publish. So the other is a cost issue. People start to discuss the cost effectiveness and so on to detect a case or to cure a case per case. However, so we really don't discuss a lot about how we can save saving of the patients by active case detection. Cambodia had good papers, but anyhow, how then this program can save the patients, patient cost for patients. And the other is actually cost for the future. I mean, if like Cambodia, if we can decline TB by the activity, so future saving is huge. So that two issues are not correctly discussed internationally yet. So then we expect such kind of discussion in future. So I'd like to close the session. So for 3 hours, thank you very much for your participation, and hand over the microphone to Caroline. So Caroline will explain also the access to the video of this meeting. Thank you.
Yes, thank you. Thank you very much to all the participants that attended today. So once this Zoom meeting closes, you will see in your browser survey, which is going to appear. So we would really appreciate if you could complete it and provide your feedback. It's important you complete the survey right after the workshop because the link is only available for a short period of time. You will receive a follow-up email in the next couple days with the link to view a recording of today's events. And we want to remind you that discussions like today's, centered around the latest research in science, take place every year at the Union World Conference on Lung Health. So join us for this year's virtual conference on 19th to the 22nd of October. And on behalf of the Union and the presenters, thank you for joining us today and enjoy the rest of your day. Thank you very much.
Thank you,
So I
Caroline.
appreciate the collaboration of the Union staff. Then really thank you very much. Then sometimes you struggle with our Japan English. so and the communication. But really, I appreciate my notes. Thank you very much.
Thank you.
Thank you.
Thank you. Bye.
Bye.